Yes, thank you for this nice introduction, and it is my honor to be here and introduce and speak about the strategies to overcome immunological barriers in kidney transplantation. I just try to share my screen now. I hope you can see it. I hope you can see my screen.
Yes, Dr. Ashraf.
Thank you. We start. In this presentation, I will introduce the increasing role of different technologies and approaches to address the problem of immunological barriers, which include the extracorporeal removal of clinically relevant antibodies in the pre-renal transplant setting. And at the end, I will also present future avenues and approaches and researches, updated researches in overcoming immunological barriers by inducing immune tolerance in the field of kidney transplantation. Actually, since the introduction of the hemodialysis before several decades, considerable development, of course, were achieved to treat patients with end-stage renal disease. And the dialysis, of course, is better tolerated now. However, despite all this success, the treatment of dialysis remain as a temporary treatment, as the transplantation as superior to the kidney transplantation, mainly because of different problems and difficulties associated with the dialysis. As you know, the mortality rate is high. There's a lot of problems with vascular access in dialysis patients, and the lifestyle, of course, is impacted by the dialysis, and the same applies for the development of psychological disorders. And of course, the economic burden of the dialysis and the costs are in the long term higher than the transplantation. Therefore, as I mentioned, the dialysis is considered as not the ultimate, but as intermediate solution. However, for the ultimate and target and goal is the transplantation, there remain 5 major immunological barriers which must be overcome. The first one, of course, the HLA barrier, which could be overcome by in the HLA level by type and screen and eventual plasma exchange and removal of the antibodies, and the T cells, of course, immunity, B cells, immunity, and antigen-presenting cells of immunity. All these maybe could be overcome using immune suppression drugs. And of course, the ABO incompatibility, which remains still also a major immunological barriers, which also could, however, overcome using blood bank type and screen, and also extracorporeal removal technologies like plasma exchange or immune absorption. The 2 major immunological barriers in the field of kidney transplantation is, of course, the HLA incompatibility and EBO incompatibility. And these 2 barriers make the transplantation program worldwide complicated. As you know, EBO incompatibility are able to initiate a life-threatening and hyperacute rejection, and the HLA antibody or donor-specific antibody are the most important reason for renal failure and rejection, acute, but also chronic rejections. To overcome immunological barriers, we use at our centers, and I think in many centers in the world, they use 3 remover technology: remover of HLA antibodies, and the EBO compatibility, and the plasma or the pair exchange. All these 3 approaches are increasingly used to overcome immunological barriers, and I will speak about all these 3 in the coming minutes. As you know, we started with the HLA barrier. The HLA molecules are representing only 0.056% of the total human genome. It is small, actually, gene, and compared to the total human genome. However, this small genome area and the chromosome 6, short arm chromosome 6 here located, has the highest, by far, the highest polymorphism in a human genome. And this polymorphism is very necessary and essential, actually, to survive. Without this polymorphism, the humanity will not survive. So as we need this huge number of different antigen binding domains of the HLA antibody, as I mentioned, to survive. The HLA antibody, as I mentioned, have different sequence of the HLA, of the binding science. This is, as I mentioned, essential because we have also millions and of micro biological, or the micro bodies like viral and bacterial microbes that must be eliminated by the body, and the HLA play the major role. However, this is as actually a double sword. This lead, of course, this incompatibility and high polymorphism leads in the field of transplantation to immune rejection of the transplanted graft, and this which we must overcome. There's a lot of studies saying that the better the match of HLA antigen are superior the long survivor of the graft, as we can see in this illustration. The better HLA match is the better graft survivor. Also, this is a study from Germany, so also the graft survival in relation to the cross-match. With zero cross-match, you have a clear better graft survivor. With more cross-match, you have less than survival of the transplanted grafts. So the benefits of less degree of matching have become, however, less relevant in the era of new and more potent immune suppressive drugs, and some centers tolerated actually large number of mismatch even because they use this immune suppressive drugs. However, the three main HLA antigens or locus which we should consider is the HLA-AAB locus, class 1, and DRB locus. Also, the other, of course, loci could have a clinical relevance. However, this is the most antigen which we consider. As you see in this figure, this is the data based from the UNOS in America. You see the waiting list. There's a huge discrepancy between number of transplanted patients and the waiting list. And this figure actually is from USA, but you find exactly the same everywhere, which means we have really problems by transplanted patient. We have the huge discrepancy between patient in the waiting list and the real transplanted patient, due mainly to the immunological barriers which I described. And as I mentioned, HLA is one of the major barriers, and therefore each program, transplant program, need a sufficient and professionally operating HLA laboratory, as the HLA laboratory is the crucial part and the backbone of each transplant program to overcome these barriers and reduce the risk of rejection in transplanted graft. Also, a transplant program need, of course, sufficient and well-operating transfusion medicine services to use also technical remover of HLA antibody and improve the number and reduce the number of years in the waiting list for patients who are waiting for transplantation. Here you need also technical skills, apheresis experience, a proper understanding of the nature of the physiological kinetics of the effector HLA antibody, along of the intra and extracellular behavior of the HLA antibody. There's different methods of desensitization to overcome the HLA barriers. However, the most technologies and approaches which are widely used is the immune absorption, which mainly in Europe use or the plasma exchange, which mainly used in America, for example, and the Arab countries. And of course, the most used drugs are rituximab and IgG, as you can see, is high. And the other drug, or the splenectomy, maybe is less frequent use than the immune absorption and plasmapheresis and rituximab and IgG. This example, what I show you, is a very impressive example from our center, how we make impossible transplantation actually possible. Here's an DSA donor specific 2 antibodies. One of them, the DQB10603, is even above 2,000, which means a strong HLA antibody, which could be associated with acute rejection of the kidney without technical removal of these HLA antibodies. And a second antibody was the RB113. As you can see here, it was also above 4,000 MFI. And after removal, the technical removal, this antibody by extracorporeal apheresis, as you can see here, we reduce the number, the MFI and the strength of the HLA antibody to almost a normal, and the transplantation went successfully. Here, another example, you see also B51, which is relevant for transplantation. As you can see here, also MFI above 12,000, which means strong, very strong HLA antibody, could be also reduced to almost 0, and the transplantation was done. Therefore, to overcome these difficult cases and immunological barriers, you need expertise in the HLA antibody, the behavior of the HLA antibody, because not all HLA antibody have clinical relevance. So you need to know the kinetic, it is dependent on the number, antigen density, titer, and a lot of other things must be considered if you want to interpret the HLA antibody and the clinical relevance of HLA antibody for transplantation. And one of the major, of course, approaches and technique in the HLA lab is the cross-match, which is the most relevant, maybe, step for at least for kidney transplantation. Here you need also to interpret the HLA cross-match proper. Here we have normal cross-match. When you're both positive, you have either DSA class 1 or class 1 and class 2. When negative, no DSA. When only beta cell positive, you have DSA to class 2 only. And when you have T cell positive without positivity beta cells, it's nonsense. This could be a non-HLA antigen, not HLA antigen. Here, the challenges is also when you have weak or no DSA, but you have a strong cross-match in both cells, you should think about the Rosen effect, which you can solve by using DDT. Also, when you have a strong DSA, but negative, total negative cross-match, you think about other things like, for example, crypt or pseud antigens, which caused, for example, by denaturated beads. Also, for this example, you have negative DSA, negative T cell, but positive beta cell cross-match, isolated positive beta cell cross-match. You think in first line about autoantibody, but also drugs like IgG or mainly rituximab can cause this reaction. So these challenges should be solved in each HLA laboratory. Also, the report should be clear to the clinician by estimating the risk of transplantation. For example, here when you have positive results, the comment, please take into consideration the positive could be associated with the graft rejection. All these logistics are needed. This figure is also from our center. As you can see here, this is the we could perform the desensitization and the extracorporeal removal of HLA antibody in vitro by in 31 patients. So 31 untransplantable patients actually were then successfully transplanted. This demonstrates the effectiveness of the removal of HLA antibody before the transplantation. And the HLA lab we recommend to establish not only the classical Luminix technology for the HLA antibody, but also other, like for example, CDC-based assay, which not used, for example, widely used in America, for example, or C1Q. However, these two techniques maybe allow you to predict better the clinical relevance of detected HLA antibody by the Luminix technology, which still use this tests at our center, as I mentioned, to better estimate and predict the clinical relevance of detected HLA antibody. As I mentioned, the removal of HLA antibody is important. Now we come to the removal of ABO antibody. It means that the blood group should be also overcome, because there's a major also limitation is the blood group. You cannot transplant all. When you see this figure, you cannot give O patient B kidney. You cannot give B patient A B kidney. You cannot give A patient A B kidney. You cannot give A O. This is very difficult, situation. And when we overcome this barriers, we will have much more better access to patients in the waiting list to transplantation. So if you transplant B kidney to A, then the recipient of blood group A, you will have hyperacute rejection, because the EBO antigen are represented in many parts of the kidney, in parenchyma and nephrons, in the glomerulocapillary endothelium, and also distal tubulus. And when you give B kidney, for example, to A patient, this antibody, which is already existing in the recipient, will attack the kidney, different part of the kidney, and you will have hyperacute rejection. So more than 30% of overall kidney are excluded because of this incompatibility. And this expands the renal recipient waiting list significantly, which associated with higher mortality rate. When you look for this publication, it's a little bit old, but still valid. You have a median of waiting list for patients with different blood group. Patient with blood group O and B must wait longer for a kidney than patient with group A and EB. This is, of course, means that patient with group B and B die earlier. This is not fair, and our role as a doctor to avoid this disadvantage of patients who have the blood group O and EB. Also, there's a publication from Harvard saying that patients with group B, for example, have double risk, long waiting in the waiting list, but also developing atherosclerosis, have heart attack. So when we look to the distribution of the blood groups, we see that the most of the patients, about 70%, have either O or B. This makes the program of transplantation complicated. We know that B and O, as I mentioned, they should wait about 5 years, less than A and EB. However, this is the majority of the patients. So it means that we need to overcome these barriers, because the mortality rate is without transplantation, as you can see in this figure higher. Here there is mortality rate could be up to 25% in some cases. However, with cadaveric kidney transplantation, 8% only, and with living kidney transplant, even only 4%. So we need to transplant the patient and overcoming if possible, every immunological barriers, because of this, to reduce the mortality rate among dialysis patients. Even when you have patients with diabetic, for example, they have 17 years less projected years of life than patients who transplanted, and non-diabetic have 11 years less than transplanted patients. This data and this statistic show us clear that we should do everything to put the patients out for the waiting list and transplant them as early as possible to avoid all these dialysis mortality-related complications. And regarding the overcome ABO incompatibility, the first who has tried to overcome this was David Hump. He tried to wash the organs. However, without success, at the end he concluded, we don't feel that the renal transplantation in the presence blood incompatibility was. This was 1955. Thomas Stercel from Pittsburgh, he was the first who considered the ABO compatibility. He is saying you can transplant only O kidney to all other blood group. And this was 1964. And since that time, the blood group was considered. No one transplanted incompatible blood group since 1964, until we have a development in the field of the removal of the EBO antibodies. And the first one who tried to remove it by plasmapheresis was the Maurice Slapik from France, 1981. He made the plasmapheresis for the first time in human successful removal of EBO antibodies from the recipients. And then the protocols were developed. We have done the European protocol, which was done by Gunnar Tiden, which still till now use this protocol, mainly in Europe, by the Sweden. This was established in the transplant surgery in Stockholm in Sweden. Also, as I mentioned, when we make the ABO incompatibility, we need also a sufficient blood bank and transfusion medicine services, as the determination of the ABO titer is essential. And of course, the correct blood grouping in the blood bank. For example, here you can see here the determination of the ABO titer, 1 to 64, 1 to 128, 1 to 156. And so on. Once you have negative reaction, you can see this titer, for example, is 1,000 to 24. And this technology, this gel, called gel centrifugation test technology, is very sensitive and recommendable for the doing and measuring the titer in the field of kidney transplantation. When you want to establish the ABO incompatible program, we recommend to start at the beginning of the program, maybe with not high titer, with 1 to 64, for example. You can start if the titer less than, for example, anti-A titer less than 64, and avoid at the beginning at least to have experience with this program, high titer. Then you can make your plasma exchange to reduce the titer up to 1 to 4 or up to 1 to 8 also is acceptable. Why am I saying this? Because studies showing that when you have high titer, for example, 1 to 128, maybe you will failed 10 desensitization, maybe you failed in 1. And here, for example, when it's very high, out of 5 cases, 3 were failed when the titer very high. So when you start to 1 to 64, the chance is high that you will succeed with your desensitization and the removal of HLA antibodies. This is after the transplantation of ABO incompatibility. There is a study saying that even the ABO antigens are reducing and decreased after the transplantation. This is one of the way why we have ABO immune tolerance after the transplantation. As I mentioned, you need, if you have to establish the successful ABO incompatible program at your hospital, you need a sufficient transfusion and sufficient, of course, HLA laboratory. This was the cases which we transplanted at our center. We have 19 ABO patients with ABO incompatibility who were successfully transplanted. The most of them, of course, have the blood group O, as we can see in this figure. This 19 patient also usually non-transplanted patient, and we overcome this barrier, ABO incompatible barrier, by the desensitization. As you can see here, this is also when you failed by 1, 2, 3, 4 plasma exchanges, you can continue. We have published this data until you have the reduced titer. In this case, was very difficult case, high risk patient, and he must be transplanted. So we continue the removal of ABO incompatible antibodies until we achieve our target, and the transplantation was done successfully. The third approach to overcome immunology barriers is the pair exchange, which also used successfully. When you have a pair, for example, husband and wife, and they are AB incompatible, for example, also HLA incompatible. You can swap this pair with other pair who also waiting for a list who may be compatible. Here, somebody, for example, blood B will be compatible. So you can swap this part and transplant the patients. You can do 1, 2 way or 3 or 4 ways kidney transplantation. At our center, we have done even 3-way kidney pair donation successfully at our hospital. That means 6 operations at the same time, 3 removal of the kidney and 3 surgical procedures to transplant the kidney. As you can see in this figure, this is the number of per kidney donation at our center. It has increased 2019. However, 2020, because mainly of Corona crisis and the pandemic, the number is reduced and actually stopped. Now we reassume the pair exchange strategy to overcome immunological barriers. But as you can see, still we have transplanted 33. It means all of this 33, 20 to what I show you, about 100 actually untransplanted cases were transplanted at our center by overcoming these immunological barriers. So our experience demonstrates the efficiency of the donor exchange program in overcoming immunological barriers in renal transplantation. Now, at the end, I want, as I mentioned at the beginning of the presentation, to introduce the avenues of future approaches and researches on overcoming immunological barriers by inducing immune tolerance in kidney transplantation. Maybe you know the model of BMT, bone marrow transplantation. The patients after bone marrow transplantation, actually, they don't need any immune suppression like kidney transplantation. It is, of course, a different setting, but it should be as a model for us for research, this bone marrow transplant model, maybe to achieve also immune tolerance in the field of solid organ transplantation, mainly kidney transplantation. As I mentioned, this is not to compare these two settings, but I think we can learn a lot of the BMT setting, particularly when you look, for example, the Tregs, T regulatory cells, which are produced in the thymus. And these cells, actually magic cells, they have a lot of functions which can help and support even in the, not only in the BMT setting, but also in the solid organ and kidney setting, as they can induce immune tolerance, they can have anti-inflammation effect, immune modulation, and even immune suppression effect. And this kidney is really easy to be isolated from peripheral blood, actually, then isolated by other technology, Clinimax technology, we call it, for example. You can isolate the CD4, CD25 positive or regular T cells. This is our publication. Our centers at the University of Regensburg, Germany, was the first center worldwide who isolated these cells for the BMT setting to avoid GVHD after bone transplantation. We have isolated these cells 2006 at our laboratory, mainly for the BMT setting. However, our sufficiency, as you can see here, we isolated about 10,000 CD4, CD25 positive cells to induce immune tolerance, to induce and prevent GVHD in BMT setting. Now, this regular T cells, CD4, CD20, which were isolated, as I mentioned, by our center 2006 and the University of Regensburg, Germany, now is increasingly used and in other setting. As I mentioned, we deplete the beta cells and enrichment than the CD24, 25 positive T cells. Here, when you look in the PubMed, for example, about using this regulatory T cells, it is now increasingly using, or there's multiple trials to use the cells not only in the BMT setting, but also in the renal transplant and solid organ transplant setting by, as I mentioned, isolated that these cells using also extracorporeal removal technologies by the donor from even autologous blood, then expanding that cells and we will then give it again to the recipients. And here, for example, publication, antigen-specific regulatory T cells in kidney transplantation, and other tolerance settings. So there's many now clinical trials ongoing, large clinical trials ongoing in the field of kidney transplantation to have these cells, regulatory T cells, to induce immune tolerance in kidney transplantation. And the initial data, which we read it, there's really encouraging. And in some centers, the infusion of T cells, regulatory T cells, lead to a clear reduction of immune suppression in the field of kidney transplantation. Maybe in the future, when we find the right dose and the right time to transplant these cells, maybe we can totally avoid the immune suppression and reach a situation like it's the case in the bone marrow transplantation. It means without any immune suppressions and achieving 100% immune tolerance in the field of kidney transplantation, which cannot exclude it. Also, for the future, we recommend, and I think the next generation sequencing should be also used in the solid organ and kidney transplantation. Now we use it increasingly in the also BMT, bone marrow transplant setting, to avoid graft rejection. However, it is less used in the solid organ and kidney transplant setting. But when you use it, we have definitely better outcome even in the field of kidney transplantation. This is only one case of many cases which we have at our laboratory. We can solve the case only by using next generation sequencing, here accurate interpretation bits across using high resolution, crucial for successful kidney transplantation. So we think that the future of the solid organ and kidney transplantation need more progress, more technologies, T cell based technology, but also other approaches like next generation sequencing technologies. In conclusion, overcoming immunological barriers turned out to influence positively and significantly the outcome of patients with end-stage renal disease in the waiting list. However, the era of modern laboratory diagnostic and the new invasive and extensive therapeutic approaches could not completely, unfortunately, prevent serious immunological complication. And till now, we have to struggle with the major immunological risk of graft and kidney rejection. Innovative strategy using cell-based therapy like regulatory T cells might minimize the risk of rejections by inducing immune tolerance and preventing a pathogenic immune response against the graft. Thank you very much for your attention.